All right, I think we can get started. Hello, everyone, and thank you for joining the American Lung Association today for our webcast on elevating lung cancer screening in cancer control work. This is the first of a series of webcasts we will be holding on our findings from our analysis of state comprehensive cancer control plans. Today's webcast will be recorded so that we can share with registrants who weren't able to make it. And before we get started, I wanted to share that it is currently our Turquoise Takeover and Lung Cancer Action Week at the Lung Association, so you can check out lungforce.org to learn more about how you can help take action to help defeat lung cancer. Next slide, please. Today, we will be covering how lung cancer screening is discussed in state comprehensive cancer control plans. And then our guest speaker from the Cancer Prevention and Research Institute of Texas will speak more specifically about how they put together the Texas Cancer Plan. Then we will be joined by our patient speaker, Donita Butler, who will talk about her experience with lung cancer screening and how it saved her life. And then finally, we will highlight some current and upcoming activities at the Lung Association before we hold Q&A. Before we move on, we should note that we're aware that the National Comprehensive Cancer Control Program is slated for elimination in the President's fiscal year 2026 budget, along with the rest of the Chronic Disease Center. However, while our advocacy to you all in the meantime in the hopes that it will be helpful moving forward in cancer control work. Next slide, please. So let's just jump in. We're going to be talking about lung cancer screening in state comprehensive cancer control plans. My name is Jacqueline Link. I'm the manager of nationwide health policy at the Lung Association. Next slide, please. As a little background on this subject, CDC's National Comprehensive Cancer Control Program provides funding and guidance to state programs to develop and implement comprehensive cancer control plans. These plans identify how coalitions and stakeholders in the state can address the burden of cancer from prevention to diagnosis, treatment, and survivorship. These plans are typically put together by state coalitions made up of the state's Department of Health, other health experts, patient organizations, and other stakeholders. The development process for these plans can vary a bit by state, so you're free to search up your own state's plan to learn more about how it was put together. And we will also have guests from the Cancer Prevention and Research Institute of Texas joining later to talk more specifically about how they developed their Texas Cancer Plan. Next slide, please. So for this project, which I completed last year, I analyzed the mention of lung cancer screening in 51 state cancer control plans. This was done back in 2024, so if you're seeing something that doesn't necessarily match your state's updated plan, that might be why. But this is a list of some of the topics I was collecting information on in each state's cancer plan, specifically looking at how the state plans were addressing lung cancer screening and the barriers to screening that exist in their state. And I'm going to go through our findings on each of these topics and then show you some interesting examples I saw in different state cancer plans. Next slide, please. Just for starters, I was looking to see if states had a lung cancer specific section in their plan where they are talking specifically and only about lung cancer and lung cancer screening. So that being said, the states in blue didn't have a section on lung cancer, and states in purple did. They had to specifically be talking about lung cancer and screening, not just mentioning it in a more general sense. Next slide, please. Getting into screening guidelines, the United States Preventive Services Task Force recommends screening for individuals age 50 to 80 with a 20-pack year history of smoking, who currently smoke or have quit in the last 15 years. Screening is crucial to diagnosing lung cancer early when it's more treatable. So for this, we were looking to see if states are mentioning the updated USPSTF guidelines for lung cancer screening. These guidelines were updated in 2021, so if the cancer plan was from before then, they might not have had updated guidelines. That might be a reason why the state is in pink. But the states in purple were citing the current and updated USPSTF lung cancer screening guidelines. States in pink had either an outdated guideline or they mentioned USPSTF at a different point in their plan. So it's implied that they're going to follow USPSTF, but not explicitly stated. States in blue mention lung cancer screening, but don't necessarily mention USPSTF guidelines. And states in white didn't mention lung cancer screening at all. Next slide, please. Just a pretty basic example comes from Kentucky of how they identified current USPSTF screenings. They included the link to the guidelines, and they also acknowledged that there are some other guidelines that patients may run into. For example, Centers for Medicare and Medicaid Services ends their screening eligibility at age 77. So this is just a good example of laying out the guidelines in your plan. Next slide, please. We were also looking to see what kind of goals states had on increasing the screening rate in the state and decreasing the prevalence of lung cancer in the state. So for this category, I was looking to see if states had a goal specific to both lowering the prevalence of lung cancer in your state and for increasing. So for this, states in purple had a goal that was specific to reducing the prevalence of lung cancer screening and a goal that was specific to increasing the lung cancer screening rate in their state. States in pink had a goal for reducing prevalence, but states in blue had a goal for increasing screening. Am I frozen for anyone else? Okay, sorry. And states in blue had a goal for increasing screening in their state, but not necessarily a goal for reducing prevalence of lung cancer. And states in white didn't have any screening or goal or prevalence goals in their state. Next slide, please. And I wanted to flag that the Lung Association actually publishes prevalence of lung cancer and frequency of lung cancer screenings, rates by state in our State of Lung Cancer report, which can be used as a great baseline if you're setting these types of goals for your state cancer plan. So in this example, we pulled an example from Ohio where they want to increase the USPSTF screening rate by 5.2% to 15% in 2025, and then to 25% in 2030. And then they use our State of Lung Cancer report as their baseline, and then they list some strategies that we'll actually loop back to on how they can increase those screening rates in their state. Next slide, please. Another great example was Texas's plan, which had clear targets for reducing late-stage lung cancer and increasing screening of at-risk adults. They also have goals for reducing the differences in prevalence of lung cancer in the state. And I know that our guest from Texas is actually going to talk more specifically about this, so I'll leave it there for now. Next slide, please. Speaking of differences in prevalence in lung cancer screening, we know that communities in lung cancer are sometimes affected differently. So, for example, communities of color are much less likely to be diagnosed early, or individuals living in rural areas or folks without insurance are less likely to get screened. So for this, I was looking to see if states are listing strategies or plans to address these types of differences of prevalence in lung cancer. Those states are in purple if they had goals specific to lung cancer in addressing these differences. Most states had more general strategies for addressing these differences in prevalence across all cancers. And then a handful of states in blue had little to no mention of reducing the differences of prevalence in cancer. Next slide, please. So one great example was California. They had a very direct plan for addressing the differences of prevalence in lung cancer screening access and for improving the rate of screening among minority and underserved communities, and different ways that they could bridge the gap for folks who are uninsured or underinsured and may not necessarily have as easy access to lung cancer screening. They also had some great language on eliminating out-of-pocket costs, which I will also be highlighting in our next slide. So we were also looking to see if states had language on reducing barriers to screening and care. There are lots of barriers that we know can affect access to screening and care for lung cancer patients, including things like cost, transportation, language barriers, distance to screening, lack of coverage, etc. And we know that payments, even as small as a few dollars, can deter patients from getting care. So we wanted to see if states were addressing that in their comprehensive cancer plans. For this, I was looking to see if states had both a plan to reduce the cost of treatment and screening, and if they had plans to reduce the structural barriers or address the structural barriers in accessing lung cancer screening and care. So there was not a lot of specific language to lung cancer. So states in purple just had more general goals to decreasing these cost and barriers um, in their state. And then states in pink had language specific to reducing cost in their state, and states in blue had language specific to reducing structural barriers. And states in white didn't really address either of those barriers in their state. Next slide, please. So one great example was Kentucky. They had a pretty detailed plan on how they were going to address barriers to screening, including out-of-pocket costs, lack of insurance coverage, and how the state intends to promote screening in their state. Next slide, please. Another example is Ohio. I mentioned before that we were going to come back to Ohio's example. This is the rest of their plan to promote screening in their state and raise the screening rate. They have lots of strategies here, such as removing cost, implementing mobile CT screening, targeting rural areas, and decreasing stigma. And I also included a small snippet from California's plan, which was to decrease or eliminate copays for screening and follow-up visits. So these are just a couple other examples of things that state plans are doing to address those types of barriers in lung cancer screening. Next slide, please. So we said a lot, but I have put together a resource summarizing all of the elements that I just talked about in plans and ways that we can continue to elevate lung cancer screening in comprehensive cancer control plans. This resource is available at lung.org, and it has a few more examples and links to all of the plans that I've mentioned. And we'll be sharing that in our wrap-up emails. Next slide, please. And with that, I'm going to turn it over to our guest speaker, Carlton Allen from the Cancer Prevention and Research Institute of Texas. Thank you.
Good afternoon. Hopefully y'all can hear me. I'm Carlton Allen. I'm the program manager for prevention at the Cancer Prevention and Research Institute of Texas, also known as CPRIT, and I'm excited to share our insights about the 2024 Texas Cancer Plan and the development and how Texas is addressing lung cancer screenings and approaches to improving screening rates. Next slide. So today I'll focus on really two main areas, sort of understanding the updated plan, the journey to its creation, and how you and others can use it as a tool to make meaningful impact in your work. The Texas Cancer Plan serves as a framework to unify against efforts against cancer. The plan requires really a coordinated actions across healthcare, public health, research, and community sectors. And so I'm here to make sure that you all understand the process it took to develop the plan and how others will be and are using it to implement actionable strategies and collaborate with others to amplify the impact. Next slide. So the Texas Cancer Plan is a roadmap for reducing the cancer burden in our state. It's a guide for diverse stakeholders in their efforts to prevent cancer to prevent and control cancer through actionable and evidence-based strategies. Um, the Texas Cancer Plan can really trace its roots back many years. I believe the first one was created in 1986, and CPRIT, my organization, we first developed the Texas Cancer Plan in 2012. So there's been many years that it's been here in the state, and it's evolved and adapt to the changing landscape and the healthcare that and new scientific advancements and developments. Next slide. Uh, the plan is not an all-inclusive list of goals and objectives and strategic actions. It's intent or the intent of the plan is really to provide a coordinated and prioritized and actionable framework to help guide cancer initiatives and reducing the burden of cancer in Texas and throughout the state. Next slide. And so really what all that means is I worked with a large number of partners across the state to make this happen, to update the plan. Texas is a little bit different. And so what that means is my organization is charged with facilitating the development of the plan and supporting its implementation. My partners at the Department of State Health Services work with providing me data for the plan, but also conduct the evaluation of the plan. They do a mid-plan evaluation and an end-of-plan evaluation to help inform public health professionals and other cancer prevention and control stakeholders across the state, how we're doing on our current measures and the progress that we've made towards the plan's goals and objectives. And then you have our coalition, like the Cancer Alliance of Texas, which it promotes the plan, but also uses the plan to help develop their framework in programs that they develop and how they're going to um, address the needs of different communities. Next slide. And so cancer continues to be a critical health issue in Texas, and I'm sure in the rest of the United States. And the landscape is always changing, and with new challenges such as disparities in care and the rise of certain cancer types, we knew it was time to update the plan. The last version of the plan was 2018, so there's been a tremendous amount of change since then. Next slide. And so a cornerstone of this updated plan was our stakeholder engagement process. And through listening sessions held across the state, we gathered feedback from diverse groups, really trying to ensure that every voice was heard and the plan was relevant to all regions. And as we click through this slide, you'll see different ways that we elicited that feedback. So feel free to click through to see some of those pictures. A few of those meetings were held with key stakeholders to gather input into the plan, and we really worked with a number of organizations, nonprofit organizations, American Cancer Society, public health professionals, different coalitions throughout the state, government councils and private organizations to really hear from them and gather their input. And we ask questions like, do you have suggestions for new strategies for any of these goals? What's missing from the plan to ensure that the plan stays relevant and current in the economic and social and technological context of cancer care. We also asked, are these objectives in the plan measurable, or Or are there tools to measure yourself against the plan? What data points do you need? And is this data source that we're using to measure ourselves still appropriate or still accurate? Next slide. And so we took the feedback gathered during those listening sections and started to shape how the Texas plan was going to look and to better address these identified needs. Some themes started to emerge and are now central to the plan, and we really wanted to make sure that we made adjustments to the plan based on regional needs and community insights. Next slide. And so you'll see here, this is our lung cancer screening goal. And so this goal increased the screening and early detection among Texans at high risk for lung cancer to increase the number of lung cancers diagnosed at an early stage and reduce lung cancer deaths. And you'll see the objectives that correlate to this goal, reduce the rate of lung cancer at late stage, and then reduce the rate of non-Hispanic Black women developing lung cancers. You'll see that the measures that are associated with these objectives our baseline rates, so and the time period where we collected those baseline rates, where we're currently at based off of the latest data that I was able to have our target rate for where we wanted to go, and the percent change based off of that target rate. And then I thought it was really important to have this document show where we kind of are based off of our national partners. Next slide. And so, and you can click through this, you'll see specific language that we use in the plan as well. And so that language includes stuff like, unfortunately, doctors diagnose 44% of lung cancer cases at a late stage when survival rate is only at 8%. You'll see language in Texas, doctors screened only 10% of high risk individuals, ranking 46 among all states, placing it at the bottom tier. And then, making sure that we talk about shared decision making and making sure that that's a, a part um, of the process when providers talk about lung cancer screenings. Next slide. And then we also wanted to make sure that whether you were a public health professional or primary care provider, community health worker, or an employer, really anyone in between that you felt equipped to take steps to help us achieve our goals and objectives. And so as you can see from this document, we really have those broken down by specific stakeholder groups and sectors, and these are just really jumping off points or starting points, suggestions that can get whether you're a group or an individual can get you started in helping us reach our goals and reach our objectives. Next slide. And then one of the other things that we did was we made this plan a digital plan. So this is our online only plan. It's compatible with mobile, so you can view it on your laptop or you can view it on your cell phone. We included integrated some Tableau maps and a graph so that and those as you can toggle through, you can see how those change, and we have incidence and mortality rates based on the ethnicity and race. We also have incidence and mortality based off of male and female for the top 10 cancers. And then we have national comparisons too. So you can see on the graph at the bottom there, showing our lung cancer rates at based off of U.S. rates and where the U.S. stands, and then where unfortunately Texas stands, and in a comparison to that. Next slide. And so hopefully you have the chance to view the plan. It's much more, a whole lot better than I'm giving it justice now on these slides. I encourage you to visit the plan. Next slide. and just hope that, by aligning your efforts with the goals and collaborating with others and staying engaged, you can help play a critical role in reducing the cancer burden, whether you live in Texas or other states across the U.S. And so there's my information, and thank you.
Thank you so much for your time. And now if we move on one more slide, I would like to introduce our patient speaker, Donita Butler. She's going to talk about her lived experience with lung cancer.
Hi, thank you for having me. My name is Donita Butler. I'm a retired IT federal employee. I'm a veteran. I'm a mother. I'm a grandmother of two adorable grandchildren, one 5.5-year-old granddaughter and a 6-year-old grandson. I'm a hiker. I love hiking, and I added recently, a year and a half ago, to my list of what I am, a lung cancer survivor. I live in Northern Virginia in Woodbridge. I want to thank you for the opportunity to be here and for all the work that you do. I mean, screening, I'm passionate about screening. Screening is why I'm still here. So thank you very much for everything that you're doing to promote screening. I had multiple risk factors. I had a smoking history. I had a family history. I had asbestos exposure during my military service, and I've lived in high radon areas all of my life. I was in two branches of the service. When I was in the Air Force, I worked on B-52s, and the B-52 brakes lining was asbestos. They were rebuilt and drilled out in the shop. I have memories of coming back off the flight line and into the shop with just the asbestos dust in the air. When I was in the Navy, I worked in a World War II building with exposed asbestos and asbestos all over the building. Mitigation efforts were going on while I was there. And the only thing that separated us employees from that was a sheet of hanging plastic. So, a smoking history plus asbestos increases the risk of lung cancer 50 to 90 times. I grew up in Cumberland County, Maine, known for high radon levels in a state that has some of the highest rates in the country. And radon, as we all know, is not all of us, many of us know, is the second leading cause of lung cancer. The world I grew up in I was born in 1955. I was raised in a time when smoking was everywhere. I was literally exposed to it from the time I was in the womb. I actually have a professional portrait of me when I was 1 year old, holding a pack of cigarettes that my grandmother put in my hands to quiet me when I was being fussy, so that the photographer could get a good picture of me. It was just part of the culture. And right out of the gate, it was what I grew up with. Doctors smoked in their office, that was glamorized. When it was very addictive. I have not met a single person that smokes that doesn't want to be a non-smoker. They may not admit it to many, but it's so addicting, and it takes many, many tries. And ultimately, Big Tobacco was held responsible because they knew what they were marketing. My screening story, well, I had, even though I had 3 significant risk factors, and I met the official guidelines for a low-dose lung cancer screening CT because of my smoking history and age, I still had to push to get a screening. The only reason I even knew a screening existed was because in 2018, I reviewed my benefits brochure from Blue Cross Blue Shield. At the time, I wasn't Medicare eligible. I was on my federal employee insurance. And I saw in there at the front, what's new, and it listed the low-dose lung cancer screening CT, and I saw that I qualified for it, and I requested it, and I got pushback on it from my, at the time, primary care physician. But I insisted that I knew my insurance would cover it, and I wanted this screening because I qualified for it. That one came back, not showing anything. Then, life kind of got away from me, right? I had grandchildren born, COVID came along, and I had anxiety with this doctor. I didn't have a good relationship with him. I avoided going to him as much as possible. So 5 years went by between screenings. I finally said it's time to change providers, and I went to a new practice, and I requested a low dose lung cancer screening CT again. This time I did not receive pushback, and that one, the same day I had the CT, I received a call that it was urgent that I get to a pulmonologist. That CT found a 2.8 centimeter nodule that pathology later revealed to be stage 1A2 adenocarcinoma. I had a resection, a robotic resection, 47 days later after that scan, and about 25% of my left upper lobe was removed in a wedge. That scan and my persistence, the advocating for myself, I believe has saved my life. What came next? Well, once again, I had to advocate. Biomarker testing wasn't done, and it was because of the stage I was at. They said it wouldn't change my treatment plan, but I wasn't satisfied with that because I knew there were oncologists that believed that everyone should have biomarker testing, and I knew that was primarily at NCIs. So I went to Johns Hopkins and requested a biomarker testing, and they pulled my tissue, and ended up I had KRAS G12C, a mutation that was once undruggable, but was now treatable thanks to research. The gaps in care, there's many, but one of them I think is mental health. Fear of recurrence doesn't end with surgery and being told it's curative, because there's a big chance of recurrence. There's a 20 to 40% chance of recurrence for my stage, and a cancer diagnosis is life-changing. As a stage 1 patient, I didn't receive an oncology consult, no biomarker testing, and no mental health support, which is those are some of the things that I advocate along with for scanning. Scanning is, I'm passionate about it. I speak to everybody because you never know who they may know that is eligible for it. I recently lost a person that reached out and befriended me at the beginning of my lung cancer diagnosis. She also was diagnosed at stage 1. Her passing is a heartbreaking reminder that early stage is still serious. I carry her with me in my advocacy. Thanks to screening and speaking up and advocating for myself, I caught my cancer early. I'm 69. I'll be 70 within just a few short months, and I'm a year and a half post-surgery. Last fall, I hiked to the top of McAfee Knob. It was 8 miles and 2,000 feet of elevation gain. I'm also fit enough to be an active part of my grandchildren's life. I hike, I camp, and I run around amusement and water parks with them. Screening saved my life. That's the power of early detection. Thank you.
Thank you, Donita. We really appreciate you sharing your story today.
Thank you.
Let's move on to the next slide. I wanted to remind folks to please drop their questions in the chat if you have any, because we'll be doing Q&A at the end. And I will turn it over to my colleague, Michaela Pittman, to talk about our upcoming activities.
Amazing. Thank you so much, Jacqueline. Carlton and Danita, thank you both so much for joining us today. And Danita, thank you so much, I think, and say it on behalf of everyone who is here, for sharing your inspiring story. And we're so glad that you're doing well. My name is Michaela Pittman, and I am the manager of nationwide lung cancer screening with the American Lung Association. For more than 120 years, the Lung Association has been America's trusted champion for lung health, and we've made it our mission to save lives by improving lung health and preventing lung disease. Over the next few slides, I will briefly walk through just a few of the many steps and activities that we've taken to defeat lung cancer through increasing lung cancer education and raising awareness of the availability of lung cancer screenings. Next slide. So as Jacqueline mentioned, probably a couple of times throughout her presentation earlier, each year during Lung Cancer Awareness Month in November, the Lung Association releases its State of Lung Cancer report. We recently released our 7th annual one back in November of 2024. And this report shows how the toll of lung cancer varies by state using lung cancer indicators and can reflect progress on screening rates and related metrics of stage of diagnosis and treatment. It also provides national statistics on lung cancer racial disparities, state of tobacco control, and comprehensive coverage of biomarker testing. So we encourage you to use this report as you review and update your state's comprehensive cancer control plans. Approximately 14.2 million Americans are at high risk for lung cancer. However, as we all know, screening is currently very much underutilized, with only about 16% of those who are eligible getting screened. And this is why the Lung Association is working hard to increase those screening rates nationwide. Next slide. In an effort to educate those who currently and have formerly smoked about the life-saving potential of lung cancer screenings, we partnered with the Ad Council and launched the very first iteration of our Save by the Scan campaign way back in August of 2017 on the 1st, which was World Lung Cancer Day. And the goal of this ongoing campaign is to direct our target audience to take a lung cancer screening eligibility quiz and to prompt a discussion with their doctor if they are at high risk. Since the campaign's launch, over 1.1 million people have taken this quiz. Next slide. The most gratifying part of this campaign and many of the other campaigns that we have is being able to see the personal stories of those lives who have been impacted as a direct result of this campaign. So on this slide, you'll see the stories of both Diane and Denise, who benefited from screening after seeing our Save by the Scan campaign billboards in their local areas. And their remarkable stories continue to inspire others to get screened and raise awareness about this life-saving scan. Next slide. We are dedicated to ensuring that everyone has equal access to screenings and strive to eliminate and close the gap on health disparities nationwide. So our lung health navigators do this through assessing, reducing, and providing free individualized support to those who are at high risk. Our navigators do this by determining eligibility for a low-dose CT or addressing eligibility concerns, supporting and locating a screening center, providing education on how to schedule and obtain an order for a low-dose CT from their primary care physician, and provide follow-ups to callers and referrals as they go through this process. We also help in finding transportation and screening assistance for those who need it, and facilitate tobacco cessation referrals to state tobacco quit lines. Next slide. The Lung Association has a breadth of lung cancer programs that extend across the cancer care continuum. I've spoken about our lung health navigators, but we also have state-specific lung cancer screening initiatives, which integrate public health equity best practices through building awareness, facilitating systems change, and reducing barriers to care among those in underserved communities. And these initiatives really work in tandem with our lung health navigators to be able to provide patient support and increase access to screening. We also have projects that educate patients on next steps of diagnosis after their doctor finds a lung nodule on a low-dose CT. Additionally, our new Watchful Waiting program gathers insights and information on key messages and resources directly from patients and caregivers during the time when their doctor is waiting and watching for any changes to a lung nodule. Our biomarker education, testing, and awareness trust and action campaigns aim to increase awareness nationwide and among Black and Hispanic patients and caregivers about the availability and importance of biomarker testing and clinical trials as a treatment option for lung cancer, and further equip and empower those individuals with the tools to confidently talk to their doctor. Finally, we have our Patient and Caregiver Network, which is a free patient-centric community that connects people living with lung diseases, including lung cancer, and their caregivers and loved ones with peers across the country through mentorship and support groups. Next slide. We know that stigma around tobacco use and lung cancer might be the reason someone would choose to not get screened for lung cancer, which is why we have created our Addressing the Stigma of Lung Cancer guide. As language and best practices continue to change, we are working to update these resources. And the Lung Association also has a series of health education courses available to you at lung.training. Our lung cancer specific courses include lung cancer basics and our lung cancer support group facilitator training. However, we encourage you to see what other health education trainings might be of interest to you. Next slide. Finally, I want to plug our next webinars in this series. So on Wednesday, June 4th at 1 p.m. Eastern, we are hosting our Radon in State Cancer Plans webinar, and we'll share the July date for the third installment of the series, which will focus on outdoor air quality in state cancer plans in the coming weeks. So I will now pass it to Hannah Green, who has been diligently monitoring the Q&A for any questions or comments. So if there's anything that you would like to ask our presenters today, you can add those questions there. Thank you so much.
Thanks, Michaela. All right, so yes, please continue to put questions in the chat. We already have a few and a couple others that were submitted in advance. Jacqueline, I think I'm going to direct this first one to you. Can you talk about the slide that you showed with whether or not cancer plans had a goal regarding lung cancer prevalence and screening? Was that based on the Healthy People 2030 guidelines?
No, I was just looking to see if states had a goal regarding prevalence and screening, but some plans probably are following the Healthy People guidelines, but not all of them. That wasn't something I was checking for.
Awesome, thank you. Carlton, I think I'm going to direct this next question to you. Can you just talk a little bit more about sort of the different stakeholders that you engaged in the development process of updating the plan and kind of how you went about identifying who you'd engage in that process?
Yeah, it was, I really tried to reach out to a wide variety. So I think initially it was reaching out to our cancer coalition in the that we have in the state, the Cancer Alliance of Texas that I mentioned, because they're actively using the Texas Cancer Plan and they're using it to, formulate some of the programs that they address across the state. But then that evolved into reaching out to whether it was navigators or providers or community health workers and even community members that were living in rural and urban areas across the state to really get a feel for what was missing. I mean, like I mentioned, the last plan was updated in 2018, so there was a whole slew of lung cancer screening guidelines and changes that I was able to pick and choose from. So I knew it needed to be updated and quite a bit because there was a drastic differences. So
Awesome, thank you. Jacqueline, I'm going to direct this next question to you as well. There's a question in the chat about around a HEDIS measure for lung cancer screening. Maybe you could just start by talking a little bit about kind of what is going on in that space, just for the group.
Sure. Yeah, so for those who don't know, the National Committee on Quality Assurance, or NCQA, is an organization that is dedicated to improving the quality of care in the US by developing and assessing those types of quality measures of care. And with funding from the Lung Association and the American Cancer Society, NCQA has actually been working on a quality measure for lung cancer screening. So we don't know the timing of that or what data the measure would use, but it'll be very helpful for incentivizing providers and plans to improve screening rates and early detection of lung cancer.
Thank you. And then I think I'm going to throw this one your way as well, Jacqueline. Can you talk a little bit more about the slide you shared around out-of-pocket costs for screening? Because, screening should be covered under most insurance plans without any cost for patients. So what exactly were you looking at there?
Yes, so it should be covered without cost, but we were also looking to see if they were addressing the costs for folks who don't have insurance to cover that. And also, many people are called in for follow-up testing, and that's all included in the diagnostic and screening stage. And people can be deterred by those costs as well if that's not covered under the umbrella of the preventive service of screening. So we were looking to see if states are trying to address that burden of cost.
And I see we have one more question here about, including the specifics of the USPSTF recommendation in a printed plan. They might update during the process. Jacqueline, were you looking at whether they had the most recent specific numbers in, or just if plans just referenced the latest USPSTF recommendations in general? Can you talk a little bit more about what you were looking for there?
It was both. So if the plan mentioned we follow updated USPSTF guidelines, I counted that as following the updated recommendations. Or if the plan laid out the specific guidelines, I counted that as following updated recommendations.
Awesome. Because I think, Kristen, your point is certainly well taken that these things, all of these documents are changing, and not always on the same timeline. So that's helpful to put in. Seeing if there's anything else, I'll put out one final call for questions. Danita, maybe I will ask one to you is just, from your experience, going through the screening process as a patient, what's sort of the one thing that you would want to leave with the group with today?
My experience was I feel very fortunate that I even knew that screening was available. If I had not looked in my brochure for my annual brochure when we go through open season, if I had not looked in that brochure, I would not even know the test existed. It had never been brought to my attention by a medical professional, and I had never seen any advertisements or literature saying anything about the screening. So that to me is a huge issue still. I am passionate about screening, and I don't care if it's a cashier or if I'm hiking on a trail, wherever I get into conversations, and the fact that I have lung cancer, had a lung cancer diagnosis comes up. I talk about screening, and I have yet to meet a person that knows that the test even exists. So to me, that's the biggest problem around screening.
Well, I think that's a really important call to action for all of us on the call today, Danita, to make sure that we're getting the word out there to everyone who qualifies and make sure that they have the best possible outcome. So I just want to thank everyone for joining us today. If you have additional questions after the webcast, feel free to reach out and we'll make sure that we send follow-up information out to everyone who joined today as well. I want to thank all of our speakers and enjoy your rest of the day, everyone. Thanks.
Thank
Thank
you.
you.
Thank you.